the Episcopal Church to the Department of Health, but now you're going to something else.
Okay, just to let you know that the webinar has started, so we'll just give colleagues a few minutes to join, and then we are going to go ahead.
Thank you.
Yeah. Greetings, everyone. Welcome. We're just giving colleagues a few minutes to join so that we can get started with our webinar, which is going to be very exciting. We've got a very exciting lineup of panelists, and hopefully we'll also have enough time for discussion and engagement. So for all the questions that you may have, please insert them for us in the Q&A. And then we will make sure that our panelists will address them. And also, if you've got experiences to share with us, suggestions to share with us, you're also welcome to include them in the chat box. If you'd like to introduce yourself and tell us who you are, where you are, you can also insert those comments in the chat section, and then at least we'll have an idea of who's joined us for the webinar. So once again, welcome to our webinar. We are going to start in a minute. So to colleagues who have just joined, welcome. Please just comment in the chat section to just let us know who you are, where you are, so that we know and we can meet you. And for any specific questions that you might have for panelists, please, you will insert them in the Q&A as we go along. Thank you very much. Welcome, colleagues. I would like to take this moment, therefore, to welcome all of you and introduce the webinar to you. Apologize for my colleagues, Rolene Wagner, who is going to join us in the course of the webinar. She is held up in an urgent meeting, but we will go ahead. All our panelists are here, so we are going to proceed. Let me start with Mr. Rampilani Mrewani, our Chief Director, District Health at National, to do the welcome address for everyone. Mr. Mrewani, I've been warned that if you are not held with a tight leash, you can end up speaking for an hour and a half, even if you are freestyle. So I ask you to please keep it brief. But do take the moment to welcome all our participants. Thank you.
Good afternoon, colleagues. Good afternoon, Prof. Thanks very much for inviting me to speak. Dear colleagues, friends, and loyal members of the National Health System, the supporters of this work that we're doing, CHAI in particular, and I want to give special appreciation to Dr. Jürgen Pillay and the team for setting up this webinar, and all other colleagues on the call. In opening and introducing, it's really for me just to express appreciation for the thought of having to come together to speak to the issues of the strengthening of primary healthcare. Primary healthcare to us is an important step, an important component of the strengthening of the national health system for the delivery of universal health coverage. Because primary healthcare stands and sits at the base of our health system, therefore making it a foundation without which we'll continue to have very, very weak health systems. Now, as the country is emerging out of the devastating 3 waves of COVID-19 pandemic, our people must find hope in a much stronger primary healthcare. When they emerge out of the dust and tears and sweat of having worked hard or having been affected adversely by COVID-19, when they arrive at our facilities, they must find that primary healthcare is the solace that they can look up to for rescue. But primary healthcare that's much stronger is going to be an important fact matter as we proceed also. That a national health insurance must be founded on a system where the primary healthcare is much stronger. It is therefore critical that as we debate today, sharing lessons, looking at promising solutions for the conundrum that we sit with, where the health systems have been weakened, challenged by various conditions, quadruple burden diseases, the devastating COVID-19. We must therefore emerge with a decision or at least lessons that we can share with the policymakers, that whereas we revitalize primary healthcare, we remember that without it, the health system will remain much weaker. I'm therefore, Chair, and everybody on the call, in opening this webinar, saying as a Department of Health, we're very excited that we've got partners such as yourselves, partners that help us in thinking, opening the doors for us, making sure that we think out of the box. Because sometimes when we are inside, we feel the temperature, we don't see any need for change. And it's only when we talk to people such as yourselves and you talk back to us that we become much more wiser. Therefore, as I conclude, we therefore need to say, how do we continue to support the health system to recover, and how to make sure that as people go to our clinics to collect chronic medication, mothers go in there because they're expecting babies, children needing immunization. How do they then get there and find that the clinics are still open? But generally, primary healthcare is able to offer them the service that they require. With that, I want to welcome everybody and officially declare this webinar open. Thank you very much, Chair. Over to you.
Thank you very much, colleagues. I hope that you are still connected in case people have power outages and other issues. But welcome, thank you very much. I would like to take this moment to just thank you for joining again, Mr. Mrewane. Thank you so much for those opening remarks. And indeed, we are forging a partnership. I've been assured by the main organizers of this event that this is going to be one of many other engagements that we are going to have going forward. Some of you would remember the dialogue that we had before COVID-19 hit, and that dialogue was supposed to set the scene for these discussions. But of course, we were really derailed by COVID-19. But here we are as we try to find a way to live in the midst of COVID-19 and continue to do other work and ensure that the work that we had started in terms of other priorities is not left behind. And in this regard, I think primary health care is really central to the work going forward. I just want to acknowledge all the people that are out really working in terms of moving this agenda forward. I know that there are people in policy, there are people in NGOs, there are people in research. I've seen people introducing themselves from various research centers, people on the ground in different countries, different provinces, all the frontline healthcare workers, community members. We would like to thank all of you for your commitment to this agenda. I just want to, open this webinar today by saying that the agenda for primary healthcare is really a long one, as we all know. But at the same time, it's really sad that we have not made the inroads that we would like to have made. And in fact, there are concerns that the original conception of primary healthcare in its entirety has been lost in many respects, and there's a need to revisit what the critical pillars of primary healthcare are, so that we can be able to not let the frustrations that we have along the way to derail us from trying to meet those ideals of primary healthcare. Many of you, of course, will know the Alma Ata Declaration of Primary Healthcare, but really in South Africa, we know the struggles that we have had to try and adopt that, given our context and our unique challenges. And we've seen since 1994 these efforts that have come in to try and really embed primary healthcare into our healthcare system and let it be the pillar, the main driving pillar of our healthcare system. But of course, when you're working with a largely curative model of healthcare, trying to really negotiate primary healthcare in that context, it can be very difficult. And even the ideals of the district health system, as we understand it, have not been met in full. People talk about how it was really important to make sure that we go beyond the district health system to a sub-district health system. But somehow we stopped along the way with the district health system. And now there've been other kind of iterations of the district health system in different ways. And we want to revisit it, but in a way it requires a lot of courage for us to revisit that agenda, because we also don't want to compromise the other priorities that we have. And we recognize the context in South Africa that we have a rich history of community-oriented primary care, again, that we lost. And in fact, other people in the world have adopted that philosophy of community-oriented primary care. They have used it to their benefit, and we somehow abandoned it. And again, there are people who are on the ground trying to revisit that same agenda to try and bring it to the fore and make sure that it remains central. And we saw in South Africa the development of the primary healthcare engineering and the ward-based outreach team as part of this effort to basically renew our health system in terms of universal health coverage, driven very much by the National Health Insurance Dialogue and discussions. But 40 years after Alma Ata, in terms of the Astana Declaration in 2018, we came back to that point to say, but we have not made strides. We have not made the kind of strides that we were hoping that we would have made by the time we get to 40 years of primary healthcare as it was conceptualized at the Alma Ata Declaration. And so here we are now. In 2020, we see this framework that is being put forward by the World Health Organization and UNICEF that begins to spell out what we could refer to as the key pillars of primary healthcare as we seek to renew it. And central to it is integration of health services, including primary healthcare, but moving away from the emphasis on the care side, or supposedly what has been driven a lot by curative clinical mentality, but to also bring in essential. COVID-19 has been really key in demonstrating to us how important this is. And again, related to that, the importance of multi-sectoral approaches and policy action. And this has become important. Complex as it is, hard as it is to do, we cannot necessarily do this without a whole society approach. We have to figure out how to do this. And lastly, the importance of empowered people and communities. And this is going to be hard to do again, because it's not necessarily natural to the way that we conceive of health system and healthcare. So we have to revisit all of these things and start to focus and think of health beyond just treating disease, and really think of it in terms of well-being, which means that we have to bring in a large component of health promotion and prevention. And if we can do that, we can then advance our agenda to incorporate what people call morbidity compression, whereby we try to prevent the extent to which people get sick and therefore have to live with the consequences of sickness, and begin to engage more with the agenda of healthy longevity, not just people living longer, but also people being healthier for longer. And these are the kind of things that I think really begin to challenge the way we conceive of healthcare, and in the way we conceive of primary healthcare, and the importance of broadening our understanding. So let's engage, colleagues, and I'm really happy that you've joined us. I'm going to first invite Mr. Ndivua Rambau, who's going to basically talk to us about the Riccidze campaign and the role of civil society. And I know that many of you understand the importance of starting at the community level and building up. Even though we understand it and talk about it, we don't actively quite engage with it. Ndivua, I'm going to ask you to please share your slides and also introduce yourself. You've got 10 minutes to basically share with us your views. It will be much appreciated. Welcome. Thank you.
Thank you very much. Good afternoon, colleagues. My name is Ndivua Rambau. I am a project officer with the Riccidze project, and we currently do community-led monitoring. Okay, I think everyone can see my slides. Can anyone confirm?
I see your slide and they are projected. Thank you very much. Very nice.
Thank you. Okay, so just as a background, South Africa has 7.8 million people living with HIV, yet the country remains dangerously off track to meet the 95-95-95 targets. So essentially, too many individuals are lost before they initiate ART, and once people who live with HIV do initiate treatment, there are severe ART continuity problems. We also find that key populations face additional barriers to accessing HIV prevention and treatment services. According to PEPFAR's 2020 data, over 500,000 people stopped treatment, were lost, or died during the year. COVID-19 has also worsened healthcare. So in 2020, there was a decline in the overall number of visits to health facilities, less HIV tests conducted, as well as less gene expert tests conducted. And the failure to make sufficient progress towards the 95-95-95 targets can be directly linked back to the crisis in our clinics in the province and poor quality public healthcare services. So just as an overview of Riccidze, Riccidze was established in 2018 and was developed by people living with HIV and activists to hold the South African government and aid agencies accountable to improve overall HIV and TB services. So it unites the entire PLHIV sector in South Africa. Currently, Riccidze monitors over 400 clinics and community healthcare centers across 29 districts in 8 provinces in South Africa. It is one of the most extensive community-led monitoring efforts in the world. Riccidze is made up of 5 PLHIV organizations, namely Treatment Action Campaign, Cenerella Plus, Positive Women's Campaign, Positive Action Campaign, and NAPWA. And we also have our associates, which is HealthGap, AMFA, and the O'Neill Institute, also known as Georgetown University. You'll see an infographic on the, well, to me, it's on my right, and that is basically showing our Riccidze cycle and how we we go about doing our community-led monitoring of the country. Our first step is that we gather evidence in facilities. We analyze the data that we have gathered from the facilities. We generate solutions and then go on to engage duty bearers. And we monitor implementation, and where we see there is no change, we advocate for change. So what is at the cornerstone of Riccidze is innovative data collection tools. So on a quarterly basis, Riccidze monitors use our quantitative and qualitative tools to carry out over 400 observations, interviews with plus minus 8,000 patients and people living with HIV, as well as key populations. We also interview facility managers, pharmacists, and adherence club facilitators at 400 clinics. We use technology for our monitoring. So in order to streamline the monitoring process, we use technology to gather the evidence. This allows us to capture the survey responses directly onto the tablet, and we provide our CMs or community monitors with those tablets. The national project team can also track site visits and analyze findings on the Riccidze dashboard. So the second step of our cycle is analyzing the data. So in real time, our dashboard takes the data uploaded by our Riccidze monitors and presents it using charts and graphs to make it easy to see changes over time and how the current monitoring effort compares to prior quarters. The dashboard puts critical aspects of the data collection together that contextualizes the concerns with an individual facility, but also at the district, provincial, and national level. The dashboard, as well as individual facility reports and district level reports, are all available on our website. And here you can peruse through it and you can find all the reports, all the data on all the provinces, all the facilities in all of the provinces that we monitor. So I'm just going to give a few examples of the Riccidze findings in our Q4 cycle, which was between August and September 2021. So the first one is on long waiting times, and long waiting times make adherence hard. So when we did our monitoring, we found that patients at 95 facilities reported an average waiting time of 4 hours or more. At 75 facilities, they reported a waiting time of 5 hours or more. At 31 facilities, they reported an average waiting time of 6 hours or more. And at 18, they reported 7 hours or more. And as much as we do our facility monitoring, we do find that it is possible to do better. So in some facilities, we did find that there were patients who said that they waited for less than an hour, and this is amongst 13 facilities in which we monitor. And there were also about 54 clinics that had a waiting time that was under 2 hours. We also find that on average, people start arriving to get in the queue as early as 5 a.m. And most patients explain that they do this so that they can be seen on time and that they're not cut off when the queues are extremely long in the facilities. 40% of patients reported that they feel very unsafe or unsafe when waiting for the clinic to open, on a scale from safe to very unsafe. So we have patients essentially who are starting to queue at 5 a.m. without any form of security to ensure that they are safe while they are queuing and waiting for the facilities to open. During our monitoring, we also found that the filing systems are quite bad or in a bad condition in close to 27% of the facilities that we monitored. So where the filing system is bad, essentially this leads to lost files, longer waiting times, and disruptions for healthcare users. And some of the concerns or complaints that we found when we were doing our monitoring is that data capturers will say that there's not enough space, and this is also echoed by facility managers where they say there's not enough space for filing or filing cabinets or a filing room, for instance. When we now move on to treatment literacy, essentially, we found that 81% of people who are living with HIV we spoke to had had a viral load test in the last year. However, only 85 of those said that a healthcare provider had actually explained what their viral load test means. And then when we go to the treatment and treatment literacy and the U equals U literacy, we found that 82% of patients who are living with HIV did understand that an undetectable viral load means that the treatment is working well. We were just a bit concerned about the 7% who don't know that they should be empowered with this information. Secondly, we also found that 74% of patients only understood or knew that an undetectable viral load would mean that they are not infectious. With regards to stockouts or shortages of medicines, close to 10% of patients across 251 clinics reported that they or someone they knew left the clinic without medicine, vaccine, or contraception that they needed in the last 3 months. And of those, 43% of the patients that we spoke to, they indicated that the stockout was even still occurring on that day. So as Riccidze, when we do hear this kind of feedback from our CMs while we're doing monitoring, we escalate the matters to the district level for a rapid resolution. So essentially at Riccidze, we are able to identify problems in clinics from a healthcare user perspective using quantitative data as well as qualitative data. So in the qualitative, we'd explain this by saying, 52% of people living with HIV received 2 months of supply of ARVs, or that 305 people living with HIV would tell us that they get reprimanded if they miss a clinic visit, while 473 said that they get sent back to the back of the queue. And these are things that make it challenging for people living with HIV to stay on treatment or even re-engage with care. And we then couple that with the qualitative data that we collect, where we now get the why behind the data essentially. And we have quotes of patients explaining that every clinic visit is a nightmare. The name calling is insulting. It makes me so cross that it makes me want to cry. So these are basically the experiences of patients of having to go to the clinics. Okay, so another step in our cycle is that we then generate solutions. So after doing our data analysis, our Riccidze monitors talk to patients, staff, and community members to generate solutions for the biggest problems that they have uncovered during the monitoring. We also organize community dialogues to feedback to the community on the data collected and hear from them what solutions would work locally. So it's in this instance that we are learning from the wisdom of communities and of community members of how we can, in collaboration with the Department of Health, improve their facilities to make them more welcoming for them. So when it comes to generating the solutions, for example, where we find that there are very long waiting times, we would recommend that there be extended clinic opening hours to attract patients and reduce an overall waiting time. Or if there's an issue of a stock out in this particular facility, we would push for the pharmacy to either fill up a vacancy or ensure that they make sure that there's always stock on hand at the facility. Okay. Once we have generated the solutions, we've analyzed our data, we move on to the next step of the cycle, which is engaging duty bearers at the clinic level. So each quarter, Riccidze monitors feedback to the facility managers and the clinic committees where they are functional on the evidence gathered and the recommended solutions. And in these meetings, we get the facility managers to basically commit to some of the recommendations that are being brought forward by the community monitors. The community monitor in instances like this is accompanied by one of the sector members from one of the PLHIV organizations that we work with, because they essentially work as a team. We also engage duty bearers at the provincial and the national level. So Riccidze attends Operation Putuma meetings, and it's a government-led cluster seeking to improve the HIV and TB response in the country. PLHIV sector members use Riccidze data to advocate within the AIDS councils. And as Riccidze, we also hold community accountability meetings with provincial leaders in which we share the findings. So community members also attend these meetings and they share their personal experiences of using the different facilities. And we also use different mediums, including video, social media, traditional media, and also through the development of case studies. So what is is important here is that it's not just about data, but accountability to communities. So duty bearers are invited, and they need to explain or must explain their plans to address the problems that are raised within the facilities. So where we have meetings with duty bearers and nothing is changing, nothing is improving, we don't just settle for that. We then move on to our next step, which is advocating for change. And when we advocate for change, this is when we build campaigns using media, protest where necessary, and also strategic activism to win in some of the improvements. So now we're just going to look at several key indicators of healthcare quality which have improved during Riccidze implementation. So with regards to waiting times, we've seen an improvement in waiting times where patient waiting times have dropped by 33% from 2020 in our Q2 to 2021 in Q4, from 6 hours to 4 hours. We've also seen better staffing levels where the percent of patients saying clinics have enough staff has increased from 25% to 31% from our Q1 to Q4 in 2020 and 2021. We're also seeing a reduction in people being sent home empty-handed in instances where there is like stock outs or shortages of certain medications. And more patients are understanding U equals U. So the percent of patients who understand U equals U has increased from 55% to 75%. And lastly, all facilities now offer PrEP, which is a huge increase from about half in 2020 Q1 when we monitored last year. So some of the key lessons learned so far in our CLM efforts is that community-led monitoring has to be regular. It's not just a once-off activity. It takes significant, well-trained staff, and it also takes time. So as any other activity that's worth doing, there's a lot of training that goes into the exercise. There's a lot of capacity building that goes into it. Engagement and advocacy components are critical to making it work. So detailed data helps uncover specific problems that cannot be dismissed just as anecdotes. So we have seen very little change just because people know about the problem. So knowing the problem and not doing anything about it is where we essentially get very little change happening. So the key is that data and advocacy need to work together in order for us to see a whole lot of change. And lastly, community-led monitoring allows one effort that holds both government, NGOs, and donors accountable for delivering quality services. So I've reached the end of our slides. For those who are interested in wanting to know more about Riccidze, we do have our resources available on our website. We have information about the model and how we go about implementing the model. Thank you very much.
Thanks very much. There have been a number of questions posed in the chat group and the Q&A, and I'll encourage you to try and respond to as many as you can when you get the chance. And can I ask the next speaker to put up your slide, please? Divo, maybe you can remove your slides so the next speaker can put up their slides.
Hi, Maury. You're up next, so I'm hoping you could put your slides up. I can also do it from my end if you'd like.
Okay, I'll put them up now. Thank you.
Thanks.
Let me just share my screen. I'm actually not given the option to share my screen, so could you put it up for me, please? Oh, actually, I see it now. Thank you. All right. Good afternoon, everyone. My name is Dr. Mori Bushani. I'm with the University of Pretoria's COPC Research Unit, and I provide clinical support to clinical associates that are working in Limpopo Province. So COPC originated with the Declaration of Alma Mater in 1978 and its update, the Astana Declaration, which both stress the importance of the provision of adequate primary health care for everyone. The move towards universal health coverage, underpinned by SDG 3, relies significantly on improving primary health care services and access globally. So COPC is one of the ways in which these goals can be achieved. Dr. Sydney and Emily Clark are two South African clinicians that are credited with pioneering the practice of COPC in the 1940s. They practiced in Polela, which is a rural settlement in then Natal, with a team that consisted of 2 medical officers, a nurse, a number of health assistants, and local nurses' aides. Over a period of 6 years, the team was able to carry out community health needs assessments by looking at the health statuses, demographics, behavior, and environment of the people who lived in Polela. They were able to map the area in detail and create multidisciplinary primary care teams where nurses examined families in their homes while another team member recorded and collected and updated data. And this significantly improved the health of the community, especially with regards to conditions such as syphilis, malnutrition, infant death, and actually improved overall mortality. Furthermore, the home visits by the nurses built relationships between the nurses and the community members. Sadly, due to a change in political leadership, COPC couldn't continue until it was revived several decades later. COPC is defined as primary care, where professionals from different disciplines and approaches work together with organizations and people in defined communities to identify and respond systematically to health and health-related needs in order to improve their health. So there are 5 COPC principles, which I will outline briefly. The first is local health and institutional analysis in a defined community. So our communities are defined geographically using geoinformation systems and ward-based catchment areas. In other words, the catchment area of a primary healthcare facility. This looks not only at those people who are ill, but also those who are at risk of developing illness later. Household registrations and individual structured health status assessments are done by community health workers to obtain baseline data. This baseline data helps us to assess the health needs of the whole community and helps us to identify institutions and organizations that are already in the community and can assist with those needs. These can be NGOs, FBOs, CBOs, and any other organizations. This is an example of a map that we were able to create with the information obtained from community health workers and clinical associates working in the area. This is also an institutional analysis that shows us structures like faith-based organizations or churches, schools, as well as post offices and other available resources in the community. The second principle is comprehensive care. Comprehensive care is a spectrum moving from health promotion to disease prevention, to treatment, to rehabilitation, and to palliation. This covers health of communities from birth right through until death. Household visits by community healthcare workers, as shown in COVID, helped with health promotion, providing health education, and identifying new cases, as well as contact tracing and adherence support. The advantage of using community healthcare workers is that they can better reach marginalized and vulnerable groups. The third principle is equity. Horizontal equity refers to the fact that people with the same needs should get the same care or access to the same resources, whereas vertical equity means that people with greater needs get greater care or more resources. For there to be equity, healthcare needs to be accessible, appropriate, affordable, and relevant to the particular community. It's important also to prioritize the health needs and interventions for each community by identifying the most important needs and planning interventions to address them. The fourth principle involves practice with science, in other words, practicing with evidence-based medicine. Practice should be based on the best, up-to-date available scientific knowledge, and COPC gathers and analyzes both quantitative and qualitative data on health from the community and uses that information to plan appropriate responses at the level of not just the individual, but households and communities as well. Secondly, medicine or healthcare is a team activity, and so a multidisciplinary approach is critical. Community healthcare workers, nurses, clinical associates, and doctors, as well as allied health professionals, and any other member of a team that can assist, all have their roles to play. The last principle is service integration around users. This is healthcare practices and services that are directed towards and organized around the needs of people who use and are serviced by healthcare providers. This needs to be person-centered and holistic, and once again, the household assessments provide the ability for us to see a full picture of the health and health-related aspects of a community. It's also important to get the community involved because this creates shared responsibility between service providers and service users. And community health committees can be established that will assist with prioritizing health needs and galvanizing organizations to assist with healthcare. So what makes COPC different from the use of community healthcare workers and robot systems? In COPC, community healthcare workers work under clinical guidance of clinical associates who can accompany them to home visits if they identify any patients who may need further care. These clinical associates and the CHWs also have the support of family physicians. ICT is used to support the delivery of services, and CHWs are integrated into the health system and become conduits of care and not just sources of information or data. There is continuous workplace learning where there's training upfront, but also regular, continuous competency development in the workplace. Second to last is care coordination, which helps to link services to other levels of care and also involves partners within the community. Lastly, COPC aims to capacitate community healthcare workers as well as the entire multidisciplinary team with the skills to improve the quality of care, and this eases some of the burden on the health system. There are multiple factors that influence COPC implementation. The first is governance. In many countries, there's poor political follow-through due to challenges at multiple levels of government and miscommunication. However, in areas where the management understood and owned COPC, there was better uptake and better results. Finance is very important because adequate financial resources are necessary in order to provide enough community healthcare workers, ensure supportive supervision, procure essential supplies and equipment, support the data management system, and accommodate operational costs such as traveling. Community health worker teams also face challenges with regard to their conditions of employment. In some areas, volunteers are less likely to stay on in the program than employed ones. Currently, community healthcare workers earn approximately 3,500 Rand a month, and they don't necessarily have the full benefits that go on with employment. They also lack career progression, and in some provinces, they're employed under NGOs and not the Department of Health. And this can create problems where there's a difference in priorities between what the DOH wants to do and the aims of the NGO. Other challenges they face are lack of equipment, a mismatch between NGO and DOH priorities, as I said. There are team dynamics, lack of other resources such as transport or office equipment, and suboptimal leadership where the team leader may already be fully committed at the clinic and unable to give further help to the CHWs. In areas where they've been successful, it's where CHWs were able to interact proactively with the households that are under their care, where they had strong management and supportive supervision, where they were embedded in the community and its culture and they were adaptable, and where they had a physician who was trained in COPC, who could champion COPC and build the team and its functionality. In primary healthcare facilities, there's fear of increased workload, which may be true in the short term, but not over the long haul. Also, in some primary healthcare facilities, CHWs are seen as extension of clinic services and end up assisting in the clinic and not doing as much work in the community as they should. The fifth factor is community participation. There are advantages to having somebody that is familiar with the community because the CHW can access support and resources. However, in some instances, there are challenges with overfamiliarity, confidentiality, and privacy. Also, if the community health worker can't meet the expectations of the community, then they lose faith in the community health worker and in COPC. Health information is important because COPC, as I mentioned previously, is evidence-based. Information systems need to be good in order to collect household data. And for this reason, we use cell phone technology to assist with the collection of the data. The data should support individuals, households, and communities. And ideally, we should be able to integrate it with the primary healthcare system information systems like the DHIS. Lastly, the training of healthcare workers also has an impact on the implementation of COPC because generally most undergraduates do not get trained in COPC and it's generally done in family medicine departments for the clinical associates and their registrars. However, we try to overcome this by giving regular training to the community healthcare workers and to the rest of the team. And we can also use sites where COPC has been successful as teaching sites for other teams. So the Declaration of Alma Mater states that the attainment of optimum health requires collaboration of health departments with other social and economic sectors, such as agriculture, education, housing, and treasury. So educating health professionals, managers, policymakers, as well as government departments such as infrastructure, water and sanitation, etc., will go a long way towards creating the collaborative environment in which COPC thrives. Thank you very much.
Thank you so much, Dr. Bushamane. Really, really appreciate it. So far, colleagues, we've had a little bit about the importance of giving voice to the community and linking that, and in a way that is data-driven, and linking that to the integration of different services and linking to the health service. But once again, making sure that we're leveraging the data in the community and the voices in the community to try and achieve that. And community health workers are key advocates in that manner. Let's move on now to the next level. And now we're talking about the sub-district kind of level of services and see how that can be strengthened. And there is a particular model from the Western Cape that Dr. Mukinda is going to share with us called the 3-feet model. Please go ahead, Dr. Mukinda. Thank you. You're most welcome.
Thank you. Good afternoon. My name is Fidel Mukinda. Strengthening the sub-district for improved health outcomes, the 3-feet model. I'm a researcher from the Majestic School of Public Health of the University of the Western Cape. I'm going to do this presentation on behalf of my colleagues, the 3-feet team, and that I salute the presence and greet all the colleagues who are part of the 3-feet team. So I'll give you an overview of the 3-feet model, the why, what, how, the evidence of impact, and the next steps. So the 3-feet model was born from the midterm review that was commissioned by the National Department of Health in around 2013 for the maternal newborn women child health and nutrition program. It was to support the district with high mortality rates that could not reach the MDGs and now the SDG goals. The mandate of this 3-feet model came from the then Minister of Health, Dr. Mutwaledi, who said it's time to look at, to go down to the 3 feet where actions are happening and where the rubber hits the roads. So this 3-feet model was implemented in 4 districts from 3 provinces, and now it's being expanded to other districts. What is the 3 feet? The 3 feet is a sub-district and district health system strengthening initiative that incorporates quality improvements, and the whole aim is to reduce maternal, perinatal, neonatal, and child mortality. Sorry, my slides. So to reduce maternal, perinatal, and child mortality. Sorry, I'm getting trouble. I can't move my slides.
We can see your slides, Doc.
Okay.
If you can maybe just scroll to the bottom left and see if you can find the arrows. Bottom left, you see those arrows that appear at the bottom there? There you go.
Yes, yes.
There
Okay.
you go, yeah.
So yeah, to reduce maternal child mortality through a process of real-time mortality and morbidity surveillance, and to release actionable intelligence that are being taken through a decision-making structure known as the monitoring and response units. And the overall expectation is to improve responsiveness, coordination, and accountability. So the 3-feet model consider and take all these actions that are happening at 3-feet level to link them to the recommendations and plans and targets that are being set at 30,000 level, which is at the national and the provincial level. So what are the key principles of the 3-feet model? So the first is what is the essence even of the theory of change of the 3-feet model is the outcome-based approach. So instead of following the planning from input, process, output, and outcomes, the 3-feet model shifts the planning from outcomes, looking backwards to the processes, the input, process, and outputs that can be used to achieve this expected outcome. And the mortality and morbidity are the measured outcome that are being measured in a real-time manner. The second one is the open tap analogy. So this shows the activities that are happening at different levels for prevention and treatments that are addressed to look at this morbidity and mortality in order to close the tap of what is flowing out of the buckets. But the focus is also on the system. The system focus of the 3-feet model mostly is about improving responsiveness and improving efficiency. And once these two are being addressed, it can automatically link to improve health as an outcome. And once you know that you need to improve responsiveness and efficiency, you can set up now or design tools that can help you to address this efficiency and responsiveness. So these are the tools that are being used by the 3-feet model. It's the 4 R's in the consolidated death reports, the monitoring and response units, and the management triangle, and lastly, the open tap analogy. So all these tools now are being applied in this system of real-time death surveillance. And the more focus is on the 4 R's, and this model is actually being updated to being applied also not only to death surveillance, but also to morbidity surveillance within the system. And all activities now are being summarized in what we call the open tap analogy dashboards. As you can see, it starts by the targets that are being set and aligned with from the national and extended to the local primary facilities and hospital, meaning at the sub-district level, looking to the outcomes. And through the process, we identify modifiable factors that are being taken into consideration to design actions, proactive and responsive actions in order to address these modifiable factors. And the whole process is now taken into the management triangle, which consists of the drivers, the navigators, the providers. The drivers are the district managers or the officers, the CEOs or the manager of primary facilities who have authority for decisions, working together in synergy with the navigators who are the information managers and the providers to provide solutions in real time to all the problems that are being identified. So this is a governance structure which brought together right people to take a right decision in real time. And it's a composition, the SS, even of the monitoring and the response units. So what are the key achievements of the 3-feet model? First of all, is about converging the clinical, the public health, and the management thinking or sciences together to create a synergy and reduce the fragmentation both at primary care facilities and hospital, bringing them together in order to improve accountability, improve responsiveness, and efficiency. And once this accountability, responsiveness, and efficiency are improved, you can, in real time, and improve the outcomes that you are expecting. And we were involved in the different districts with the 3-feet model in different series of evaluations that can be found in these selected publications, and one can access. And I'm going to share just a few with you. So one is through the observations in the areas, in the district where the 3-feet model was implemented, we observed reduction really and decrease in maternal mortality from about 37 to about 17 over a 3-year period. Not only for maternal mortality, we also observed a decline in case fatality for acute malnutrition that went from 28 to about 9 over a 4-year period. And these are happening. We got message, report from the district that this decline are being observed even now without the support of without the external supports, meaning that the district they buy in. They buy into the concepts, particularly the death surveillance, 24 hours death reports and the 48 hours review. Those principles of the 3 feet are still being applied in the district, and improvements are being observed. And before lastly, this is about improving the synergy and creating the collaboration, a network of collaboration within the district. So these graphs show you how through in the site where the 3 feet was implemented, how primary care facilities and district hospitals are working together as a team, and the sub-district and all other actors working together, and we can see the central and key role played by the Chief Executive Officer in bringing together the people to work together as a network and as a collaborative. And what now are the next steps into the 3 feet? So the first is trying to incorporate these 3 feet into the district planning. Because there is a new generation of district, the idea is to expand to other districts and sub-districts and create a network of peer learning, and to expand to the real-time mobility surveillance, following a clinical governance in order to improve diagnostic and reporting, but also to create, to tackle the clinicians and the teams of primary care and the district to work together in a journey of learning and set up continuous professional development training. But also the next step is also to involve in more research and evaluation activities. We welcome all your questions and comments, and thank you so much for listening. Thank you.
Thank you so much, Dr. Mukinda. I think our colleagues have so far been doing a great job of answering the questions in the Q&A. And if participants, really attendees have questions for you, we can also address them in the Q&A. So the last talk we have really, it's about integrating vertical programs. You can see that for primary healthcare, we need a comprehensive approach and we need a different way of doing things. And nearly all of us, we know Dr. Keith Clot, who's going from the Western Cape, who's going to really give us that bird's eye view and the policy thinking on how this can be done, so that we can then support the sort of innovative models that we have so far seen. Keith, over to you. We can see your presentation. Yeah, excellent.
Thank you so much. It's really an absolute honor and privilege to be with all of you. Let me start off, and I'm very glad what was presented before me. There's a long road from Alma-Ata 1978 to Astana 2018, which is 40 years. But if you add when the first COPC pilots was done in South Africa, you add another 30 years before that, it's 70 years since those initial thoughts. It's brought us to this point, and I think I will take this as the point of departure, that the Astana Declaration, or the new documents presented by WHO and UNICEF, comes up with these 3 key pillars. And I really would like to just concentrate my talk around orientating ourselves to these 3. So the first one is to meet people's health need through comprehensive and integrated services through their life course. The second one is to systematically address broader social determinants of health through evidence-based policies and actions across sectors. And then the third one is the empowerment of individuals and families to optimize their own health. So a renewed vision for PHC. This is quite a useful definition. So it is PHC as a whole of society approach to health that aims to ensure the highest possible level of health and well-being and the equitable distribution by focusing on people's needs and preferences. As early along possible, the continuum from health promotion, disease prevention, all the way to treatment, rehabilitation, and palliative care, and as close as feasible to their everyday environment. So my thesis is here, what is required is a paradigm shift, is to shift from a disease focus to a people focus. So we need to recognize service users as partners in managing their health, that we design our health system around the needs and their expectations, that we provide care that is socially relevant and responsive, and the service model that's orientated towards health and well-being rather than disease. The second thing is that we move from a reactive to a proactive health system. So we offer close to user interdisciplinary teams in the defined geographic area, greater capability for prevention and promotion, and that we keep pace with the changing needs of the service users across their lifespan. And in essence, it is almost taken us 70 years to say, let's move away from selective primary care to comprehensive primary care as intended. So it's an approach that's very nicely captured by Rifkin. It's the values of equity, community participation, and intersectoral collaboration, rather than effectiveness, efficiency, and cost effectiveness. The concept of health as well-being, rather than as health as the absence of disease. The orientation and accountability. The success depends on linkages between health and other sectors, community support and capacity building, rather than the vertical health dependent on vertical management support. And then the time span, a much more longer term population and public health dependent orientation, rather than short term programmatic dependent, and in many cases donor driven. So moving from vision to action, I'm going to use a few examples from the Western Cape of what we've learned recently. So the first one is redefining what the service does. So on the right top hand side is a conceptual frame that we use to determine what we call Healthcare 2030 in our province. And it's really moving from a reactive to a proactive system. So you can see on that we move from complex disabling conditions to mostly healthy. And we look in the life course, children, adolescents, adults and elderly. What we've done is we've converted that into a service matrix, which talks about health promotion, prevention, cure, rehabilitation, and palliation. And then for mostly healthy, defined episode of care, long-term conditions. So we believe that this is the frame within which you should be defining what a service should do. You can see in here, there is no disease orientation. We're talking about a continuum of health promotion to palliation, and we're talking about mostly healthy people to people with complex disabling conditions. So it's a generic frame to decide what you need to do. We talk about three concepts. It's redesign how the service should work in practice. The first one is a care continuum, and that's the interconnectedness of the system, so that we can have universally accessible healthcare, mostly effective, efficient, appropriate health technology, defines level of care, a continuity of care across that, and mobilizing a range of resources to be able to do that. And then also to take responsibility for the healthy and the ill in the defined geographic area and proactively engages people. The second one is the model of care, which is the healthcare team. It places the user at the center of their care to involve them as an informed partner. And the team has the capability of a cross-professional working. There's sound clinical governance. As healthcare workers that's capable of providing healthcare, high quality care. And there's continuous quality improvement in the way that the model of care is rendered. And then the last one is a care pathway, which is distinct from a care continuum. And these things is in a sense, how a patient navigates a healthcare system, not how a healthcare system is designed by levels of care and continuum. It should be gender and culturally sensitive. It should support users of how to navigate the system. There should be a seamless user transition and strong feedback loops and strong collaborative care path networks between health and social care systems. So what does that mean? So we have just come through COVID, or we are just come to the third wave of COVID. We are going to live with COVID for a while, but we've drawn from our lessons from COVID and applied it. And I'm going to use two examples for you. The first one is TB service redesign. And just to show you what the lessons from COVID has allowed us to do, and we have negotiated this, consulted this with civil society, and we own it through our Provincial Council of AIDS and TB, and it was launched on World TB Day by the Premier of the province. But anyway, so one of the things we learned from the pandemic, it's community prevention. So the issue about a clear focus of public awareness, personal protective behaviors, and mask wearing, cough etiquette, and ventilation has got a huge implication for TB. The second thing is the issue about screening, the paper-based, the online, the mobile screening tools. It allows us, the patient agency, to self-screen and to leverage that for increased detection of the disease earlier in the treatment and for earlier treatment initiation. Probably the single biggest lesson we've learned in the Western Cape was leveraging of hotspot identification response. So it's adequate, timely, and accessible public data to understand your epidemic within one's local context. And this is, we're very proud to say, we've now leveraged of the dashboard for COVID in the Western Cape. It's inspired the development of a delivery of the first of its kind public TB dashboard in South Africa that is now operational in the Western Cape, and it will be made public very soon. Similar thing is about test and trace, and that's the ability to look at the results from COVID PCR testing and now TB sputum gene expert testing. And it's really about getting that results to people and exploring the efficiencies and sharing results via SMS, a contact call center, and leveraging all of those. And then the last two lessons is the virtual case management. So we've learned quite a lot about telemedicine consultations, which is data-driven and risk stratified, and clinicians calling people at most risk in terms of clinical deterioration, so that we will apply this to the management of TB. And then also alternate means of medicine delivery. It would be very important to understand how we actually leverage of getting medication to people and do this for TB. The second example I want to use is addressing social determinants of violence, drawing from the COVID lessons. It was incredible, you know, we stumbled onto this thing. We got a real-time data system in emergency centers. And it was like switching on a light and switching it off whenever alcohol was available and alcohol was not available, in terms of what happens directly in emergency centers the next day for alcohol-related trauma. So it is the most sensitive measure. So alcohol access has got, alcohol availability has got a direct impact on violence and trauma. So what we've done in the Western Cape, because of the health playing a role in COVID, we were invited into the space because of evidence and data to lead a public health approach to reducing violence in the Western Cape. So what do? We look at best evidence to say, what are the key things from the WHO in terms of reducing violence? Everybody can recognize these are there's 10 best buys or 10 very good evidence-informed things. One of them is reduce the availability and harmful use of alcohol, but very importantly, reduce access to firearms and knives, strengthen the relationship between children and the caregivers, which is very much in the first 1,000 days in the early child, develop education and life skills for children to be able to navigate the ability for conflict resolution, creating safe spaces, empowering women socially and economically, and then changing the harmful social norms for violence and gender. So from a trauma in emergency units, there's a safety initiative that talks much broader, which is evidence-based, and now is underpinned by a public health approach, and very much underpinned by the following things under the how. It's that we use the data to understand the problem. The health data is very refined, and we can pinpoint it to geographic areas, deaths, ambulance data, EC data, and pinpoint it to local neighborhoods. The evidence to inform a selection and design of intervention in geographic areas. And then the big thing that PHC talks about, a whole of society approach of bringing all the sectors together to combat the issue of violence. And we've now developed a strong theory of change, and that is how will we get there? To effective policing, through social protective factors against violence, which is the violence prevention ones, and then also through safe spaces, And I'm just, for the sake of this meeting, just really just look at that relationship between children and caregivers, the harmful use of alcohol and drug consumption, which is where the health department's interest started with this, and then change harmful social norms of violence and gender, and then strengthen the ability for people to navigate conflict resolution. So that brings me to how should we act systematically? Now, this is a big paradigm shift required. A system thinking lens is a very useful one, because our conventional thinking is really much about thinking in terms of parts, where the system thinking take you to thinking in terms of the whole. Being concerned with the content in the conventional thinking, but being concerned with process. Focus on fixing symptoms, which is conventional thinking. Focus on fixing underlying dynamics. Concerned with the sign and blame, but looking for patterns, finding the patterns, and then really believe that change is emergent and unpredictable, and go with the flow and learn as you go. That's the kind of frame that I think is what's needed to get the paradigm shift, to get PHC on the way it should be, on its original intention. So PHC is central to a broader health system reform agenda. We are starting in the Western Cape and believe that this is what we want to launch. On the left-hand side is what the UNICEF and WHO is recommending. We should link PHC with UHC, SDGs, bring all of that together. We believe very strongly, from where we're sitting, that there are 4 types of reforms required. The first one is a service delivery reform, and the purpose of which is to be a people-centered healthcare system. The second one is governance reform, and that's to build trust in the healthcare system. The third one is a public policy reform, and I've just used the example of alcohol control, and that's to promote public policy to protect the health and well-being of communities. And the fourth one is the UHC reform, which is really about creating an equitable healthcare system where the resources are equitably distributed. So in conclusion, there's key principles, I think, for making this paradigm shift. Principle 1, we should be brave enough to build a strong foundation for change with the users of the system. We should go where we fear to go many times when we go and have technological and technical solutions. It's talk to the people that use our system and help them to understand how better to change the system. The second one is engaging all stakeholders. And this means that we have to explore competing views, uncomfortable competing views, because people have different perspectives and different views. Principle 3 is you need to actually accommodate diverse perspectives. We must build a social compact out of all of these perspectives. And then we strongly believe that civil society is our biggest ally in achieving that. The fourth principle is support collective responsibility for the unintended consequences, because you're going to move a system in a way and then you just go as you go and you respond. And lastly is to commit to a compelling shared vision and develop strategies to achieve the goals and aims of real primary healthcare. So in conclusion, I believe COVID has offered us an ideal opportunity to engage and empower users to develop this people-centered PHC system. This is an ideal time where we find ourselves now to redesign healthcare services around the needs and expectations of people. And it's essential to address social determinants through a whole of society approach. Thank you very much.
Thank you so much, Keith. I don't even know how to summarize that. It was brilliant, to the point, and really covered the essence of what we need to do. With the time that we have left, let me invite all the panelists to comment on the first question that I would like to raise. When I looked at the Q&A, there is a number of questions relating to the issue of how you link innovation to the existing system, the interface. So Ndiviwe, for you, it's going to be how you take Riccidze and how do you link it to the clinics and to health services interface with government. I know you've answered this question in the Q&A, but I would like you to reflect on your experience. The general sense that we have is that people are generally resistant to change. And when you're bringing the kind of innovation that you bring, especially because, as Keith is saying, giving voice to the community is something that is uncomfortable for a lot of us. We would rather people just buy what we are asking. So just tell us a little bit about that. And the same goes to you, Maury, as well. In terms of COPC, How do you interface it with the current health services, and how is that working? Are there lessons there, key issues there that we need to take into account for anyone who is thinking about taking this kind of innovation forward? And the same thing to you, Fidel, as well, like the 3 feet model, another innovation. How do you link it? Keith, for you, it's this paradigm shift from diseases to people. How is it possible for the health system to adopt such a shift? And yes, you have the advantage of being internal as well. However, just tell us how, for someone who is in another province, who might want to embark on the same kind of shift. And perhaps let's start with Indiviwe, and then we can come all the way to Chloe. Yeah.
Okay, thank you. So in terms of, interfacing with government, what Riccidze has done is that it has been working hand in hand with the National Department of Health to ensure that there is the success of the project. So we currently have an MOU with the National Department of Health, which has assisted in us gaining access in provinces and facilities, and for us to essentially be able to do our work. And I think what also makes us unique is that we don't just hold onto this data. We go and we present it back to facility managers. We also go back and present at district levels as well as provincial levels, as well as through our community accountability meetings. So in everything we do, we also try to include the government or the Department of Health in everything. So if we're having an accountability meeting, we won't say we're having an accountability meeting. We also invite the DOH to also come and have make comments and also make commitments on everything we've presented. As well. So I think that has really helped Riccidze in gaining traction and also having the successes that we've had.
Yeah, no, very good point. And I think that agreement from the start and continuous engagement can really help resolve the issue of the interface for innovation, especially when that is done from the beginning. And for you, Mori?
So the misconception with implementing COPC is that it's a completely different program to what's already happening on the ground, which it isn't. So the aim is to actually come alongside what the Department of Health and the Public Service is doing and to help with implementing the program. So the aim is not to take over, but for it to be able to run on its own after some time. So we do provide support, and one of the ways we support is by using technology. So a lot of the community healthcare workers collect data on a paper-based system, and there are usually issues with photocopy or availability of paper, etc. So using a cell phone-based system means that your data collection is much, much easier and more accurate. And this is why we say it would be wonderful if we can integrate it with the DHIS, because the information that is gathered is exactly the same thing that the department gathers.
Thanks so much. So essentially, what we ought to do is to think of innovation in a way that enhances the services. And if you can think about ways to make things easy for people who are already providing the services, and that way, innovation that you're bringing in is not seen as an add-on or a burden. It's actually really maximizing what they're doing, and they can leverage the innovation to actually make their work a lot easier. So I think that really makes sense. But I do think that there is something here about changing mindsets. How are you dealing with that? Because there's a little bit of that involved, and it can, as we said, encounter a little bit of resistance.
Yes, we have encountered resistance, but we've also found people who are very willing to work with us. And so what we do is we work with the willing, and what tends to happen is that it ripples out. So initially when you speak about COPC, people say we don't understand, but once there's a certain facility that's actually doing COPC in their community and they actually see what we're talking about, then we get people that come and say, oh, okay, no, we understand. We would actually like to also do that with you. Okay,
so really leveraging diffusion of innovation and knowledge. That's really good point. Okay, so let's go to you, Fidel. What about your experience?
Okay, so I think from the 3-feet perspective, first of all, we need to know that frontline health professionals are already overwhelmed with a lot of requests. Right. So we should not add on, but add in what they are doing, meaning using the same thing that they're doing, but try to spice, to change the way of approaching things. And most importantly, I think we need to being able to identify champions who can understand the model, especially if those champions are those drivers of the system. And they can take it forward to the next level. But most importantly, it will be interesting at the district level to have the buy-in of those who are in charge of the district. I think that will allow for the model to be implemented and to move forward.
Yeah, and really it's going to be something that we have to address because we are leaning on monitors, navigators, champions to help us kind of begin to transform the way we provide healthcare services. And if we are going to involve these people, we have to think about how they interface with the services. But as you say, it should be done in a way that is sensitive to the people that are already on the ground. So let's go to Keith. Let's hear from your side, the shifting paradigm. How does one navigate this sort of interfaces when it comes to such a major shift, especially in mindset and practice?
I think for me, Musa, the most important thing is that a paradigm shift starts with every one of us. I think one of the big things that I've learned is the humility that comes with requiring a paradigm shift. I think the point is we have more power, if we make ourselves vulnerable, if we say we don't have all the answers, if we enter the space truly to say, I've got lots to learn. And actually, who do we think, why do we think we would know better than the people that live in a specific context, better than them, how to solve their problems? So for me, the fundamental problem lies, I think, is with arrogance. And that's a powerful word, but it is more the challenge of going back to being humble. I think one of the things I've learned by doing this, I've been very fortunate in the Western Cape to head up something called the whole of society approach. Actually, it started with the whole of government approach. We spent 2 years just talking to different government departments to understand what their roles are and municipalities. And actually, as the health sector, I always came back to my colleagues and they always laughed because I said to them, who makes us as the health sector think we can solve everybody's problems? We go in there, listen and say the whole of society and the whole of government is actually not our problem, it's everybody's problem. The point is just go in with humility, understand that people come with different strengths, different things. So for me, the answer is, Musa, is the comfort we all have to move into what I call a space of collaborative governance. Now that's a very, very difficult thing to navigate. But for me, collaborative governance is we all come together. We all agree together that we have a social compact, that we're going to fix everything, but we will hold the space together. That for me is the thing. I've not heard a single community structure where you go in and you go cap in hand and say, we're here to listen to you. We believe we can do things better, but we have to do it with you, not us telling you, but us with you. Because people will also say, well, it's your job to deliver this. We can't run away from the fact that there's certain obligations that we have, but it's how we execute the obligations. That for me is the fundamental issue. Thank you.
And really it speaks to all these models of community empowerment where we talk about how we navigate power with communities, letting go of power over communities, starting to embrace power with communities. And if we think of it across the board, then we might be able to make progress. So that's really powerful. Thank you so much. Let me invite Jürgen to basically pick up the last question before. And Jürgen, as you pick up that question and raise it, please also wrap up for us and close for us. Thank you.
Great, thanks very much. And firstly, let me thank you, Musa, for moderating so effectively. And secondly, to thank the presenters as well as people who have asked questions on the chat group. And we will continue to respond to them. As Marang said, the presentations will be available on the Dropbox, and she's made that available as well. So you have all the presentations, and the recording will be put in the same Dropbox as well, and we'll make the recording available to everyone as well. The key question that we have is, the title we had put for this was promising approaches. I think we've moved now from promising approaches to exciting approaches.
Yeah.
And we've got nuggets from each of the 4 exciting approaches. And the key now is to figure out, what do we do with all these nuggets? How do we take these nuggets and redesign the primary healthcare platform as part of universal health coverage? Or put in another way, how do we connect these dots? So we have dots in communities, we have dots in facilities, we have dots in healthcare workers, we have dots in other government departments. And how do we connect up these dots? And I think Keith's presentation has given us some ideas about how to connect up the dots. The next question, of course, is how do we take the dots to scale? You see, doing it in one district, in one province, is really proof of concept. Once we have the evidence that this gives us the desired outcomes, and we would have to understand what kind of indicators we will use to monitor and measure change, hopefully positive, how do we then take this to scale? And we will then have to work across government departments with academic institutions, NGOs, communities, to figure out how best to do this. And I think the NHI discussion that we are currently having in South Africa and colleagues in other parts of the world, because we have colleagues from many parts of the world joining this conversation today, and I'd like to thank them for joining us as well. How do we do this in a country, and how do we do this in a few countries, so that we don't waste another 70 years, as Keith reminded us. So we've got to have, together with WHO, UNICEF, as well as global leaders, we've got to have a plan of action to take this in a very concrete way into communities, being led by communities, and take it to scale. Because we've run out of time now, I can't ask the panelists to tell us how we join up the dots. But if any of them have, 1 or 2 sentences they would like to add, I would encourage them and invite them to tell us how they think we can join up the dots. If any of them want to venture. If not, this is obviously going to be a topic for the next seminar. As you said, Musa, this is going to be a series of seminars on primary healthcare. And we will invite people also to give us ideas about what the next topic or sets of topics can be. So, Musa, let me hand over back to you.
Thank you so much, Jürgen. Really much appreciated. And also, I would like to thank all the panelists. Please, if you've got thoughts, send them to us through Marang. As you know, we will think about how to plan the next session around these key questions that Jürgen has tabled for us. And thank all the participants, the attendees. Really exciting. And really, I think that this agenda is really beginning to take shape. And we're looking forward to the next session. Thanks to you, Jürgen, and to Helen Schneider as well for the background work you've done on this. I hope that you've also picked up some things to keep thinking about. I'm really looking forward to further discussions. Colleagues, thank you for today, and all the best for the rest of the week. And please, if you've got any inputs, share them with us. Any thoughts, share them with us. Any examples of things we can discuss for the next webinar, please share with us. And we hope that you can continue to be part of this community and the conversation. Thank you very much, colleagues, and all the best. Let's close the webinar. Much appreciated.
Thanks, everyone.
Thank you.
Bye-bye.